So John, you said the procedure goes back how far?
Corindus first developed the robot and marketed it about 7 years ago. The first generation robot was capable of advancing balloons and guide wires and so forth, but not with the amount of finesse that we see now. The second generation has only been out recently. We are actually the 11th center to install this second generation robot in the country. The closest to us outside the state of Tennessee is Atlanta.
And this is the only one in Tennessee?
This will be the only one in Tennessee.
Can you explain in simple terms what exactly it does so we can explain to other people what it does?
When you're doing coronary endovascular work, you want to be very precise and very delicate because you are manipulating devices within a coronary artery. This robotic device enables us to make very fine, very precise movements. I can rotate a guide wire 30 degrees at a time through an entire 360-degree arc. I can advance a guide wire 1 millimeter at a time or withdraw it 1 millimeter at a time. The robot system also will warn me if I'm encountering resistance to any of these movements, which can avert some complications from the procedure.
What additional training do you do then, doctor, to use this?
I did training in New York, went to an animal lab and had didactic or lectures, more or less. Okay. And I put about 3 stents in a pig.
Now we've been doing stents, everybody's been doing stents, but they've been doing them.
We've been doing stents manually. Stents first hit the market about 1995. They dramatically changed the whole face of coronary vascular work. And I predict that this is going to be another leap forward in technology. Because not only can I sit here at this console while the patient is over there on the table, but I could be in the next room doing this. Eventually, I could be at a remote site doing this. So it actually provides the technology, provides the treatment to a lot more individuals by virtue of bringing the technology to them.
How much did this machine cost?
I have to refer you to the hospital for that. It wasn't cheap.
And y'all are going to do the first procedure tomorrow. Can you talk about that a little bit?
And the first procedure will be done tomorrow morning. The gentleman that's coming in has a blockage in an artery that's in a very crucial branch point in the vessel. So positioning of this stent is going to be very exact. If it's not placed in the exact right position, it could cause problems with the other branch vessel.
Doctor, will patients want to shift to this, or will it be done in situations that right now that require it, that you could not do by hand?
Well, this is going to be a learning situation for us, obviously. As we get more adept at the procedure, I believe that we will shift a large volume.
It will make the other obsolete almost.
I think it will, yes. It not only improves the treatment of the patient, but it also helps the staff and the physicians. The reduction of radiation exposure to the physician and the staff is significant.
Can you talk about some other benefits of this? You just mentioned the radiation. You're able to do very precise things. Any other benefits of this the robot?
Any other benefits? Well, to the operator, as you can tell yourself, Steve, wearing that heavy lead apron all day long can lead to a lot of back problems, and hopefully this will extend the career of a lot of our cardiologists in the community.
Will this shorten the length of these kinds of procedures?
Actually, I suspect it will lengthen the procedure initially, but once again, if we can get to the point we were doing remote cases, and they're trying to get this set up where they can do the first trans-ocean procedure this fall. So an operator will be somewhere on one side of the ocean and the patient and robot will be on the other.
So the ability here then would be that other hospitals could tie into this type of procedure, and you could be the surgeon.
We know from our treatment of heart attacks that the faster that a patient can get treatment, the better the outcome. So if I can bring this treatment into the community hospital and they don't have to wait on transfer times to get here, much better outcomes.
How easy is it to move?
Oh, we won't be able to move the equipment. The equipment
Just-
is,
you'll
once
just
installed,
install.
stays. But
But it would be feasible for smaller hospitals then to have access to
it
this
would
type
be
of.
feasible for smaller hospitals to have that access, and it would be possible for operators, even here in Jackson, to take care of patients in Martin, in Lexington, in Selmer, et cetera.
Because surgeries have just about disappeared.
Uh,
I mean,
the
there are very few
numbers-
staff surgeons.
Yeah, the numbers of heart surgeons are, the numbers of heart surgeries are declining nationally as more and more people are receiving stents.
Okay. Are there other applications into this type of technology? I mean, this is very specific to heart, obviously.
Well, this will be expanded into the peripheral vascular area as well, and that includes stenting vessels in the legs for peripheral arterial disease, perhaps even eventually stenting vessels in the neck for cerebrovascular disease. So there are widespread applications for this technology.
Has the stent changed then as a result of this?
No, not really.
Okay, so the stent is the same.
Mhm.
It's just a different way of.
Well, the stent has been modified over the last 20 years, but it's still basically a metal scaffold. Now we use both plain metal scaffolds and we use drug-coated scaffolds.
Will all the surgeons start moving to this and doing this?
I predict that they will. Yes.
Okay. So what is the learning curve there, John?
The learning curve is, actually the equipment is very intuitive.
You've already been doing this,
Yeah.
right?
When we do angioplasty and stents already, we are doing basically a procedure where we're watching what's happening on a screen in front of us. But as you see over here, we are right up in front of a big screen that's across the table from us. So there is some eye strain. Here, I'm 18 inches away from the screen. This is a high definition monitor. I'll be able to see what I'm doing much more clearly than I could up there. The procedure, the advantages of the procedure is I don't have to wear lead over here. I've got lead protection right there.
Are there any disadvantages to this?
None that I'm aware of.
And for the patient, is it less intrusive than doing this by hand or something?
It is virtually the same procedure,
Okay. Just
on the patient's
patient's
experience.
sense,
Yeah.
okay.
We have shifted a large number of our procedures to radial access,
Okay.
and you'll be able to do this by radial access as well. Radial access reduces the risk for vascular complications. After the completion of the procedure, you don't have to lay flat on your back. You can climb off that table and walk to the recovery room if you really needed to.